Thank you very much. Good evening, everybody. I would like to begin by thanking the Physician Association of Vadodara for inviting me for this discussion regarding the combination of GLP-1 and GIP. Now that Dr. Mona Shah has already set the tone for this combination therapy, I would now like to talk about the first molecule which uses this combination, the GLP-1 GIP combination, to help us in achieving good glycemic control and at the same time also help the patient in losing weight. So for the last few years, we have had the benefit of using GLP-1 analogs, and they have provided excellent results for glycemic control, for weight loss, for cardiac and renal protection. But as Dr. Mona Shah said, GIP has been there for quite some time. But when used alone, it was not able to achieve the benefits that were similar to GLP-1, was not able to achieve good glycemic control in clinical practice. One of the reasons was that in diabetic patients, there is a lot of GIP resistance, and there are some studies which show that GIP works well when there is some degree of glycemic control. If the blood sugar levels are already quite high, then GIP alone is not able to increase the insulin release to a significant amount, and that's why glycemic control is not achieved. However, when you use it in patients who have had some degree of glycemic control, I am talking about GIP here, this is basic science, I'm not talking about the molecule GLP-1 GIP, but if you use purely GIP in patients who have had a poor glycemic control, the studies did not find very good glycemic control. Only when glycemic control was already established, GIP was able to improve insulin release and help the patient in losing weight. So that brought us to the combination of GLP-1 and GIP, which had both the benefits. It helped in reducing the weight of the patient to a significant amount, to a greater extent than GLP-1 alone. We will look at the SURPASS 2 study for the same. And it also achieved better glycemic control. Some of the figures that are mentioned in the studies here and which have been replicated across the entire SURPASS trial program will be surprising to many of you. The HbA1c reduction potential of this drug is quite significant, and at the same time about 80 to 90% of patients enrolled in these trials achieved an HbA1c target below 7%. So coming to the disclaimer, it's similar to Dr. Mona Shah's. So please avoid using these photos or videos on social media. I am contracted to speak for Eli Lilly obviously and to a number of other multinational companies. So some of these slides are already discussed in the previous presentation. We know about the incretin effect now, that when you use oral glucose as compared to IV glucose, there is a greater insulin release. At the same time, this increased insulin release is not seen with IV glucose because of the release of GLP-1 and GIP that happens from the L cells and the K cells of the intestine. So these incretins are responsible for the majority of the insulin release from the pancreatic beta cells. This slide was also similar to the previous presentation. I will try and talk about those things which have not been discussed in the previous presentation. GIP is secreted by the duodenum and the proximal jejunum, while GLP-1 is secreted by the distal ileal cells. Both of these are stimulated by glucose, but GIP is also stimulated by lipid in the food. And this is the basic difference between the roles of GLP-1 and GIP in regulation of metabolism. So GLP-1 has been known for quite some time to reduce appetite by increasing satiety. It also increases nausea to an extent, and that's why the food intake goes down. At the level of the pancreas, it increases insulin secretion to a significant amount, and it reduces glucagon secretion in two states, in the hyperglycemic state and in the normoglycemic state. During hypoglycemic state, the GLP-1 molecule does not reduce glucagon secretion. It has no effect on glucagon secretion in the hypoglycemic state. This is a major contradiction between GLP-1 and GIP action. In the stomach, it reduces gastric emptying, and that's why it is responsible for some of the GI side effects. Coming to the GIP activity, like GLP-1, it also reduces food intake. However, there is not a significant amount of nausea which is seen according to the research, because it does not have a major impact on gastric emptying. It also increases insulin secretion just like GLP-1, but as I said, the difference is mainly at the level of glucagon secretion from the alpha cells of the pancreas. So the primary mechanism of GIP on pancreatic alpha cells is to increase glucagon release. This is mainly in the hypoglycemic state and in the normoglycemic state, whereby it will increase glucagon release. When the patient is in a hyperglycemic state, this molecule, GIP molecule, will increase insulin secretion, and the action of insulin on alpha cell is to reduce glucagon secretion. So indirectly, GIP will reduce glucagon secretion in the hyperglycemic state, which we actually want. So that is the major difference between the action of GLP-1 and GIP on glucagon secretion. The major other difference between GLP-1 and GIP, which has also been discussed in the previous presentation, is its effect on the adipose tissue. Now, here again I would like to add a couple of new points. The first thing is that there are two major enzymes which are present in the adipose tissue. One is the lipoprotein lipase enzyme and the second is the hormone sensitive lipase. So suffice to say that lipoprotein lipase is a beneficial enzyme for the individual from the point of view of metabolic improvement, while hormone sensitive lipase is acted upon by counter regulatory hormones like glucagon, epinephrine and steroids. So the major action of GIP on adipose tissue is to increase the blood supply to the adipose tissue, increase the insulin sensitivity at the level of the adipose tissue, increase storage of fat in the adipose tissue and prevent mobilization of fat from the adipose tissue to the periphery, to the liver, reduce the risk of fatty liver, reduce the mobilization of fat from adipose tissue to pancreas, to muscles, and thereby improve insulin sensitivity. It increases storage capacity, it reduces inflammation and immune cell activation. So this slide was also discussed previously. Although GLP-1 analogs have been in use for quite some time, it is GIP which has a major incretin effect. 2/3 of the incretin effect that is seen after ingestion of food is due to GIP, while 1/3 is by GLP-1, and about 33% of the total effect, the total insulin release that occurs after ingestion of oral glucose is by glucose itself. So there are not just GLP receptors on the pancreatic beta cells, but there are actually glucose sensors also on the pancreatic beta cells. So these are the sensors which are responsible for immediate insulin release. While if we look at the incretin effect, 2/3 is by GIP and 1/3 is by GLP-1. So it creates a more significant effect on insulin release. This is again the action of GIP on adipose tissue. I will not go into the details of the same, it has already been discussed previously. And we will move on to the introduction of the molecule, which is Tirzepatide, the combination of GLP-1 and GIP. So it is the first molecule that has a combination activity on both GIP and GLP-1 receptors. Actually, the molecule is a native, similar to the native GIP sequence. It does not have a GLP-1 sequence in it. It is mainly similar to the native GIP molecule. It is a 39 amino acid molecule with a 20 carbon long chain. I'm sure many of you must be using insulins like Degludec and previously Levemir. So these insulins have a longer duration of action because of the fatty acid chain, which combines to albumin and prolongs the action of the insulin. Similar method has been used with this molecule, where it has a 39 amino acid sequence similar to GIP, native GIP, and it has a 20 carbon side chain. This 20 carbon side chain is responsible for the prolonged action of the molecule. It is not easily susceptible to DPP-4 mediated degradation. It has a 5-day half-life. So a 5-day half-life is responsible for a once weekly injection or dosing. And as I said, it binds to albumin. Its dosage does not need to be modified in patients with hepatic or renal impairment. So what is the mechanism of action of Tirzepatide? It combines the benefits of GLP-1 and GIP. So at the level of the central nervous system, it will reduce the appetite and food intake of the patient. At the level of the liver, as I said earlier, it prevents mobilization of fat from adipose tissue to liver. So it reduces liver fat content. In the pancreas also, it reduces intrapancreatic fat deposition, so improves beta cell sensitivity, increases insulin secretion and reduces glucagon secretion. So here, as I said, there is a caveat to glucagon secretion. It reduces glucagon secretion, the molecule reduces glucagon secretion mainly in the hyperglycemic state through the indirect action on insulin or the beta cells. But in the hypoglycemic or in the normoglycemic state, it will either increase the glucagon or keep it at a level state. The combination also reduces gastric emptying due to the effect on GLP-1, and it has a systemic action of improved insulin sensitivity. One more thing I would like to add over here, the action of this molecule on the native GIP receptor. So in the GIP receptor, it has an action similar to the native GIP molecule, 100% effect similar to endogenous GIP production. But its effect on the GLP-1 receptor is 1/5 of the total GLP-1 action that is seen by endogenous GLP-1 molecule. So basically, it is less effective on GLP-1 receptor and more effective on the GIP receptor. It has been studied extensively for both management of diabetes and management of obesity. My job here is to talk to you about the SURPASS clinical trial program. So basically it involved about 6,200 patients. There are multiple trials, SURPASS trials. The first trial was in treatment naive diabetic patients where Tirzepatide was compared to placebo. The second trial was its comparison against semaglutide in the patients who were already on 1500 milligrams of metformin daily. The third trial was on patients who were on metformin plus SGLT2 inhibitors, and the comparison was against degludec. So it has been compared against the industry benchmarks or the best molecules in the treatment armamentarium. It has been compared against semaglutide, it has been compared against degludec, and then it has been compared against glargine in patients who are already on metformin and other drugs, mainly to look at the cardiovascular safety of the molecule. The SURPASS 4 trial mainly looked at the cardiovascular safety, and it was found to be non-inferior to glargine as far as cardiovascular protection was concerned. It did not show any cardiovascular protection data because the trial was not aimed at showing cardiovascular protection. It mainly compared to glargine to see whether it is safe from the cardiovascular point of view or not. And then there was the SURPASS 5 trial, where patients who were already on insulin and metformin were given either placebo or Tirzepatide, and comparison was done for HbA1c reduction, weight loss. So all of these trials were done to compare the effect of Tirzepatide versus other molecules or placebo on the HbA1c reduction and the weight loss. There is a SURPASS 6 trial also, where patients were already on glargine, and the comparison was between Tirzepatide and insulin Lispro. So gradually, as you move from SURPASS 1 to SURPASS 6, the patients who are enrolled in the study are on increasing number of medications. In the first trial, the patients were treatment naive. In the second trial, they were on metformin. In the third trial, they were on metformin and SGLT2 inhibitors. In the fourth trial, they were on metformin, sulfonylureas and SGLT2 inhibitors. In the fifth trial, they were on metformin and insulin. And in the sixth trial, it was compared against basal bolus insulin regimen. So how is Tirzepatide superior to GLP-1 analogs, semaglutide? So this is the SURPASS 2 trial, where the baseline HbA1c, about 1800 patients were studied. 8.3% was the baseline HbA1c, 8 years was the baseline duration of diabetes. The baseline BMI was 33, the baseline abdominal circumference was 108, the baseline weight was 93 kgs, about 50% of the patients were female. And the patients were divided into 4 groups. First group received 5 milligram Tirzepatide, the second 10, the third 15, and the fourth group received 1 milligram of semaglutide. This was on an increasing dosage, starting with 2.5 milligram weekly Tirzepatide, increasing to 5 after 1 month, 7.5 after 2 months, and so on and so forth. This was a 40-week study. And these are the results. You can see that Mounjaro or Tirzepatide demonstrated superior mean HbA1c reduction, even at the lowest dose, even at 5 milligram dosage. That comparison of Tirzepatide versus semaglutide was in favor of Tirzepatide. There was 2.1% HbA1c reduction at 40 weeks with Tirzepatide, 2.4% with 10 milligrams Tirzepatide, and 2.5% with 15 milligram Tirzepatide, which was a significant HbA1c reduction. And all of these were better than the HbA1c reduction seen with semaglutide, which was 1.9%. And this was a sustained HbA1c reduction. So one of the important measures of a drug in achieving glycemic control is the ability of glycemic control. In a previous talk, there was talk about the ADOPT trial, where pioglitazone was shown to have the longest glycemic durability in comparison to other molecules. Similarly, we want glycemic durability with newer drugs also. And in this trial, the HbA1c reduction that was seen with Tirzepatide was sustained over a period of 40 weeks. This was the slide that I was talking to you about in the beginning of my presentation, that the numbers will probably surprise most people. So the numbers are 86 to 92% of patients achieved an HbA1c level below 7%. With Tirzepatide, with increasing doses of Tirzepatide, and it was always better than semaglutide. And about 30 to 50% patients achieved an HbA1c which was less than 5.7%, which is obviously in the normoglycemic range with Tirzepatide, of course, as compared to semaglutide. And the weight loss potential is also significant. Even the lowest possible dosage, lowest possible maintenance dose of 5 milligram achieved a weight loss of 7.8 kgs over 40 weeks. And it increased up to, there was a total weight loss of up to 12.4 kgs with the 15 milligram dosage. And this was also sustained over a period of time, over a period of 40 weeks. You can see that 12.4 kg weight loss was achieved over 40 weeks with Tirzepatide 15 milligram as compared to semaglutide 1 milligram, which achieved only 6.2 kg weight loss. I'm saying only here as a relative term. For a 93 kg patient, even 6 kg weight loss is significant. But when you compare it with Tirzepatide 15 milligram, it is only half of what Tirzepatide achieves. And this is another endpoint which was studied in the trial, where a composite of HbA1c less than 6.5%, weight loss of more than 10%, and absence of hypoglycemia. So this is the wonderful thing about the newer drugs. You achieve good glycemic control, you achieve weight loss, you achieve cardiac protection, but this is all without the increased risk of hypoglycemia. So in this composite of HbA1c, weight loss, and lack of hypoglycemia, about 60% patients who were on 15 milligrams tirzepatide achieved the composite. 10 milligram tirzepatide patients 51%, and 5 milligram tirzepatide patients 32% achieved this composite, all of which was better than semaglutide. Coming to the side effect profile, it is similar to the GLP-1 side effect profile: nausea, diarrhea, vomiting, seen in the to the tune of about 15 to 18%. In most patients. The discontinuation rate is not that much, about 6% with 5 milligram tirzepatide and 8.5% with 15 milligram tirzepatide. Obviously, it is more likely to cause nausea and diarrhea as compared to semaglutide, since it is a combination of two incretins, but it is a comparison. The incidence of hypoglycemia was also similar to injection semaglutide. So, I think most of the things related to the comparison between semaglutide and tirzepatide have been covered in the discussion. I would only like to summarize by saying that it is the first and in fact the only approved, US FDA approved single molecule combination of GLP-1 and GIP receptor agonist. It shows superior HbA1c reduction, and the HbA1c reduction is fantastic even in comparison to semaglutide, which in itself is a very good molecule for HbA1c reduction and weight loss. There is superior weight reduction across the 3 doses when compared to injection semaglutide, and the safety profile of Mounjaro or tirzepatide is also similar to GLP-1 RS. Thank you very much for your patient listening.